I'm Dr. Veronica Racho. I practice mainly in Mindanao, which is the southern portion of the Philippines. I practice in the main city of Mindanao, which is Davao City. So my practice is mainly endocrinology, diabetes, and metabolism in Davao Doctors Hospital. I took my fellowship in Manila, okay, which is the key city, and I took it in the University of the Philippines, Philippine General Hospital. So I stayed there for 2 years, and then I came back to Davao City to start my own practice. And I've been in Davao Doctors Hospital for the past 20 years already. So I took most of my fellowship program in the University of the Philippines. The basics is basically the American Diabetes Association and the American Association for Clinical Endocrinologists um, recommend the use of metformin and lifestyle modification. And then they divide the patients into those with atherosclerotic cardiovascular disease, and for which they advocate a GLP1, a glucagon-like peptide 1 agonist like dulaglutide, semaglutide, and liraglutide, which are all have been shown to have cardiovascular benefits. And then those with heart failure, they advocate SGLT2 inhibitors like empagliflozin, canagliflozin, and dapagliflozin. And those with CKD, they recommend the use of a GLP1 inhibitor or a SGLT2 inhibitor for this class of patients. Now, weight loss is generally recommended, so around 5 to 10% is the key for getting the diabetes under control. And there are newer drugs in the pipeline. So we have our GLP1, GIP, gastrointestinal peptide analogs. We have your SGLT1 and SGLT2 analogs like your sotagliflozin, and the newer PPAR gamma and PPAR alpha agonists, as well as G protein coupled mediators and sodium bile acid transporters, as well as modulators of gut microbiota. So these are the newer agents that are under the pipeline at the moment for treatment of diabetes. There's a paper on nutraceuticals in metabolic syndrome and in type 2 diabetes. So, for example, turmeric, which is a ginger-like plant, the active compound is curcumin. So it has anti-inflammatory and antioxidant properties. So it suppresses NF-kappa B production. So therefore, there is a decrease in the inflammatory cascade, and it downregulates tumor necrosis factor alpha expression, and it suppresses plasminogen activator inhibitor, which is a prothrombotic molecule. And then it also interrupts leptin, and it increases adiponectin level. Adiponectin is anti-atherogenic and anti-inflammatory, and it has been shown to be more or less the hormone to go to in terms of controlling blood sugar levels as well as hypertension and obesity. Now, garlic, the active compound is allicin. So it's anti-inflammatory and antioxidant. It increases insulin sensitivity in fructose-fed rats. And then in adults, it has been shown if you eat aged garlic for 12 weeks, it has been shown to improve adiponectin level. And the sulfur compounds in garlic actually fight reactive oxygen species mediated inflammation. Cinnamon are the active compound is polyphenols. They are antithrombotic, anti-inflammatory, and increases insulin sensitivity. So it improves fasting glucose and body composition. So grapes, resveratrol is the active compound. It decreases adipogenesis and increases lipolysis, and it decreases insulin resistance. And there are clinical studies to show that in fatty liver and in insulin resistance, they have promising results. Diabetes per se is a low-grade inflammatory situation. And in the gut microbiota, depending on what gut microbiomes you have in your gut microbiota, the lactobacillus, the species have been shown to be protective, and then the microbiome is also sensitive to lipopolysaccharides, and this actually mediates inflammation. So it also perpetuates obesity. If you alter the gut microbiota, there might be effects in terms of obesity, as well as for downgrading the inflammation, the inflammatory process, the inflammatory cascade. Magnesium deficiency is very common, but it's not necessarily detected. We find it usually during inpatient admissions. The magnesium deficiency actually promotes more C-reactive protein species, and it actually underplays the inflammatory cascade. So it actually makes the inflammatory cascade a little more active. And then the magnesium itself, it plays a key role in many post-enzymatic effects, especially in insulin signaling. So the normal magnesium range is around 0.75 to 0.95. So the recommended daily allowance is about 420 milligrams, which is about 2 millimoles per liter. And if you have low magnesium levels in the insulin receptor, the tyrosine kinase pathway of signaling is actually altered if you have low magnesium level. So there's actually insulin insensitivity. So there is it actually promotes lower uptake of glucose. Okay. And it doesn't matter what salts you use. So the doses vary from 250 to 600 milligrams. And it doesn't matter whether you're using sulfate, oxide, carbonate, chloride, citrate, maleate, acetate, or gluconate. It's the same. So the dose to be given is between 250 to 600 milligrams between 7 days to 6 months, according to some papers. There is a paper on it. They compared aerobic exercise versus strength training exercise, and aerobic exercise actually showed more lowering in glycated hemoglobin. So they can both parameters showed a drop in glycated hemoglobin by around 0.6%. And there's an increase in glucose uptake by at least 40%. And they actually regulate leptin and adiponectin levels also. So there is upregulation of the antioxidant processes and reduction in free radical formation with exercise. So regular physical exercise is really an important component of the treatment of type 2 diabetes. The primary objective was to provide real-world data on patient characteristics, the disease management, and healthcare utilization in type 2 diabetes. And the secondary objective was to determine the risk factors associated with micro or macrovascular complications, to assess the impact of complications on treatment choices, and to determine association between the complication and outcomes. So in effect, there were 12 sites, and there were 10 sites sites in Manila, and there was one site in Visayas and one site in Mindanao, which was my site. And mostly these were private sites. And 52% of the participants were family medicine, 33% were endocrinologists, and 14% were cardiologists. And the demographics, 92% were Asian, 5.3% were Asian Chinese, and 1.2% were East Asian. They had very high educational backgrounds. 84% had university or higher education, and around 10% had secondary schooling, around 7 to 13 years of schooling. And then one third were employed full time, one third were retired, so around 33%. 5% were not working, and 11% were self-employed. Mostly, they did not have health insurance. So 42% did not have health insurance, and 27% had private insurance, and 12% had government insurance. So out of the 705 patients, 699 had complete demographics. So 50% were male, 44% had only type 2 diabetes, 26% had hypertension, and 7% had dyslipidemia. The mean age was around 57 years old. They did not have metabolic syndrome. Their waist circumference was low, around 70 centimeters, and their duration of diabetes was 6 years. Their A1C levels was 7%, and their blood pressure levels were 128/78. And they had stage 2 kidney disease, around an EGFR of around 85. And then 56% had very good control, around 7%, but 8.8% had a level of 8 to 9, and 16% had a level of 9%. Statin use was not very common, around 63% only, and aspirin was very low, 13%. ACE and ARBs around 53%, and beta blockers 9%. For treatment, there were more people on DPP inhibitors at that particular time, because that was the time that the SGLT2s were starting to be promoted first. So metformin monotherapy was the most, 29%, and DPP monotherapy 4%, and SGLT2 2%. And then the combination of DPP4 and metformin was 22%. 11% had macrovascular complications, and 13% have microvascular complications. So for the microvascular complications, chronic kidney disease was number one, followed by retinopathy and peripheral neuropathy, and albuminuria. Erectile dysfunction also came in at around 0.4%. And for the macrovascular complications, strokes were number one, around 3.3%, followed by coronary artery disease around 2.3%, and diabetic foot around 1.9%, and heart failure 1.7%. So these were the preliminary results of the Discover trial. The prevalence of diabetes mellitus in the Philippines is around 7%. So 7%. So that would be, if we're about 111 million, that would be 7 million, 7.5 more or less million patients. And you're right. We see a lot younger patients, so 30 years old and younger. And then, but we still see a lot of the elderly population, so 65 and above, so 60 and above, okay, as diabetics. And then for the younger generation, they usually come in because of complications, and that's the time that we figure out that they are diabetic to start with. The GLP1 analogs are a very exciting class of diabetes medications, because they offer effects other than type 2 diabetes control. They offer effects on obesity, non-alcoholic fatty liver, and even in chronic kidney disease. So one drug hits multiple targets, and I think for me personally, I think what I'm waiting for is the oral semaglutide. Because most of the GLP-1s are injectables, and that can be a barrier, as well as the cost for treatment, because in the Philippines we are an out of pocket economy, so we pay for our own medications. So the oral semaglutide would be very promising in terms of hitting the blood sugar controls, as well as kidney complications, and fatty liver complications. And the GIP1 GLP analogs are actually also sounds promising, but I have no idea what the analogs are at the moment. There are a lot of patients with diabetes who develop depression. Okay, so especially males, especially when they have complications like erectile dysfunction. So depression is part of the situation, and we do have to cross-refer our patients with the psychiatrist to help them manage the ongoing depression. Or some people have anxiety and anxiety attacks, and they have panic attacks also, because their blood sugar levels are very, very high. And cost is also a factor in terms of treatment, because if the costs of medications are prohibitive, this will actually limit our patients' ability to use the more useful medications, like the GLP-1 analogs. So we do work a lot with the other consultants, like the mental health professionals, psychologists, and psychiatrists, and they address the issue of depression in our patients, usually with medications. And some have good results with counseling. I think the thing is, metabolic syndrome is sometimes overlooked. Okay. So sometimes we overlook it because it's just a set of criteria. So your criteria of waist circumference more than 102 or 88 in females, your blood sugar levels more than 100, your HDL of more than 50 in males or 40 in females. So it's a bunch of criteria, but it actually works in figuring out who will be the next patient who will develop type 2 diabetes, or who is the next patient that you are going to need to treat in the future. So metabolic syndrome is also an inflammatory situation. Okay, so if you can address the problems early on, then maybe they don't need to go into type 2 diabetes, or maybe you can help your patient more in terms of targeting weight loss, or targeting their triglyceride levels, or targeting their blood sugar levels while it's still in the impaired fasting glucose stage. Yeah, I wanted to be an astronaut when I was a small kid, or a flight stewardess, But I ended up being a doctor. Probably the workout for being an astronaut that was more daunting. Okay, and my uncle didn't want me to be a flight stewardess, so I ended up being a doctor.